Hi, everybody. My name is Kara Mannor. I use she, her pronouns. I have short, dark and gray hair. I'm wearing glasses and a multicolored jacket, and I'm sitting against a green background. I'm a doctoral candidate affiliated with the University of Michigan School of Public Health. My talk today is titled Large and Heterogeneous: Disability, Health Disparities, and the Politics of Public Health Recognition. As a disabled person who has spent 15 years working in or studying public health, I've repeatedly bumped up against disability, even when I'm not working on projects with a specific disability focus. As many of you attending this symposium can likely attest, this bumping up against disability in fields like public health can be both difficult and painful because it often means bearing witness to or being subjected to ableism. But these encounters can also be incredibly revealing insofar as they disclose the assumptions, logics, values, and politics of a space. So it's with this curiosity that I'm approaching a developing project. Broadly, I'm interested in understanding the more recent uptake of the term ableism within public health, and as a possible instance of interest convergence, leading to new forms of biomedicalization of disability. But today, I'm just going to present one snapshot from that work. And that snapshot is a discourse analysis of texts associated with the initial decision in 2023 to reject disabled people as a health disparities population by the National Institute of Minority Health and Health Disparities. I'll note here that much of the talk is limited to this set of events and their immediate aftermath, and I draw on some of the sort of immediate reaction and advocacy and analysis around it, but then I hope to contribute a deeper analysis to think about that moment in a framework that we can use today. So I'll look forward to posing some questions and hopefully be in conversation with folks about these dynamics and the implications of the current moment. And I'll make one more note here. The institutions portrayed in this talk use person first language, so I'll use that terminology, but I'll also use the term disabled people just out of habit. Okay, first, for folks who may not be familiar, the National Institutes of Health, or NIH, is a biomedical institution that funds a broad range of health research in the US. There are very many institutes within NIH. An important one for this story is the National Institute of Minority Health and Health Disparities, and I'll refer to that as NIMHD. So since the 1990s, what is known today or in the recent past as NIMHD has grown in size and scope. With the Affordable Care Act, NIMHD was granted the authority to plan, review, coordinate, and evaluate minority health and health disparities research supported by NIH institutes and centers. So this authority includes making the decision to classify different groups in the US as health disparities populations. And this brings me to my second point. So this term, health disparities population, is not merely rhetorical. The Public Health Service Act, when a group receives this designation, the Public Health Service Act stipulates that NIMHD is responsible for establishing, for example, centers of excellence focused on research, education, and training. It also triggers an important set of institutional processes in the mobilization of resources. Now, there are many definitions of health disparities. In this law, the Public Health Service Act, the definition of health disparities is actually quite generic. It only stipulates that disparities are differences in health outcomes, and it gives priority to minority populations. However, in public health scholarship and practice, the term health disparities can take on many definitions, but in general, it's used to signify a particular kind of differences. It's used to sort of indicate that differences in health outcomes are usually due to social, economic, and environmental conditions. And if we change those conditions, we can change the differences between groups and their health outcomes. So multiple groups have been granted the health disparity designation before 2023, before disabled people were considered. And so here I'm using institutional language. Those groups included racial and ethnic minority groups, persons with low socioeconomic status, sexual and gender minority groups. They got the designation in 2016. as well as underserved rural populations. So, how did NIH come to consider persons with disabilities for this health disparity designation? So I'm going to condense the timeline of events, but one of the first formal steps was the formation of an NIH work group on persons with disabilities, and this started in 2021. And so here I want to underscore that this 2021 work group was actually formed to consider workforce diversity issues. So this work group decided if we're going to address workforce diversity, we really need to change the charge of our work group to consider other issues like this health disparities designation. They maintain that in order to address ableism that shut disabled people out of research positions, they also had to contend with the ways that ableism impacts knowledge production in public health. And so they put this health disparity designation and related issues on their agenda. So they do their work and come up with a set of recommendations. And off of that, another NIMHD specific work group is formed, and their charge is to then consider this designation, the health disparity designation for people with disabilities. And so they do their work over the course of about a year, and then they present their findings and recommendation in early September 2023 at the 64th meeting of the National Advisory Council on Minority Health and Health Disparities. Okay, so, and you can find this presentation online, I think, at least the last time I checked a couple weeks ago. The work group is presenting their recommendation at this meeting, and they frame it in terms of let's think about the risks and benefits of making a health disparities designation for disabled people. So they outline two benefits. First, they say if we make this designation, there could be an increase in research related to disparities among disabled people. And then secondly, there could be a greater inclusion of researchers with disabilities at NIH. And these were benefits. Then they outline the risks. The risks they consider are more numerous. I'm not going to discuss them all here, but I'll highlight a few. So first, the work group argues that this designation for disabled people had the high potential for quote unquote mission creep and loss of focus at NIMHD. Secondly, they argued that limited budget and staff could be overwhelmed by an influx of application to study a broad and heterogeneous population. That's how they can characterize disabled people. And then third, the designation could reduce accountability for institutes or centers to fund disability research. So in short, according to the work group, designating persons with disabilities as a health disparities population would be a risky endeavor, and for public health folks, risk is bad, so they recommended rejecting the designation. So next, I want to make sense of the risks and the rationales that the work group used through some themes that I identified in my discourse analysis, and I'll draw on the evidence that the work group cites to reject the designation. Okay, so this first theme is that biomedical models are the default and implicit templates for professionals granted the authority to make decisions about disabled people. So here, one piece of evidence the work group highlights is that NIH funding for disability-related research ranged from $6.6 to $11.8 billion over the past several years. And they give examples of this research, including studies on brain disorders, aging, mental health, and 8 other health conditions. So what we can glean here is that it's clear that for this work group, disability is about medical conditions and a potentially long list of medical conditions. I'll also offer you a quote here from a work group member. A key gap is that currently there are several definitions of disability, and therefore it is not clear who will be the population with health disparities that will be impacted by this designation, unquote. And to illustrate this point, this work group member names multiple ways that people may come to be disabled. For example, through a condition present at birth or early in life, the experience of injury, illness, or through a chronic condition. So what gets highlighted actually in the initial response to this rejection, and what I'll highlight here, is that what they've cited as multiple definitions of disability are not definitions of disability. To describe the ways that someone might acquire a disability is to simply stake out some diversity in different concepts that are related to disability. So we can see here that there is some confusion on the work group's part that is kind of getting projected into the process. And what's more, we know in public health that populations are contested concepts. There are many definitions of various social positions and statuses, like race and like socioeconomic status. And this doesn't typically prevent us from doing public health research on disparities, but here it's being made into a problem with respect to disability. So what I argue here is that the default and implicit operation of biomedical thinking creates tensions and internal contradictions that make a recommendation to reject the designation of health disparities for disabled people almost a foregone conclusion. If you assume that disability is an individual level pathology, it's hard to imagine how you could think of disabled people as a health disparity population. Addressing individual pathology isn't about changing those social, economic, or environmental conditions. It's about condition-specific medical intervention. So the arguments of the work group here demonstrate that when you're not attentive to the concepts that you're using to think about disability, you can't be aware of how those concepts delimit the questions that you ask. This next theme is theme 2. Health disparities is a corruptible category that sets the boundaries for legitimate claims to a particular kind of difference. As I mentioned before, one risk of the designation that the work group prevented was this threat of mission creep and loss of focus at NIMHD. And they described this as the potential that resources for racial and ethnic minorities and sexual and gender minority groups would be compromised if disabled people were granted this designation. They also made this appeal to intersectionality as an alternative to the designation, stating, quote, there's a research need to examine the intersection between disability and the health outcomes of racial, ethnic, and other disparities populations. So the work group is asserting here that disabled people don't have a legitimate claim to this particular kind of difference that these other social groups do. That particular kind of difference is about systems and social conditions that impact health. For the work group, again, disabled people's health is about individual and personal conditions. So to include disabled people as a health disparities population, according to that logic, would be compromising. It would corrupt the meaning of the category. The work group presented the health disparities designation here as a zero-sum game, right? The pitting of marginalized groups against each other, which only reinforces and reproduces social inequity that health disparities research is supposed to investigate and then help mitigate. And finally, I'll turn to theme 3, large and heterogeneous. Disabled people should remain segregated from health disparities research in public health. In a presentation that was only a few minutes longer than the one I'm giving today, the phrase large and heterogeneous was used multiple times to characterize disabled people. This was particularly evocative for me, and I'll offer another quote from the work group. Quote, this large and heterogeneous population of people with disabilities needs to have its own place of focus in the NIH to explore the relevant health disparities, unquote. The work group also advocated for the need to, quote, establish whether all populations with disabilities experience health disparities or whether some populations with disabilities are more at risk of experiencing health disparities, unquote. So here, what I understand to be the logic is constituting disabled people as both threats to and drains on health equity efforts. It's saying that disabled people will compromise, again, the category of health disparities and siphon resources away from legitimate groups if it's given the same status of these other groups. So, surely we can't include them all. That's what the work group is saying. Disability is too big, it's too burdensome, it will overwhelm the system, it asks too much. Isn't the $6 to $11 billion spent to study a laundry list of medical conditions enough? And in my analysis and assessment, the rationale for the rejection of health disparities designation is a blatant, if unattended, espousal of logics that continue to rationalize and justify the segregation of disabled people away from public and community spaces. And all this is being framed as for the good of disabled people. These logics are those that many of us encounter navigating university campuses, doctors' offices, and more intimate spaces. And again, these are the dynamics that that health disparities research are supposed to help understand, not reproduce. So where does this leave us? So as I mentioned at the top, the initial decision to reject the designation It passed the advisory council and it passed unanimously, but then disabled researchers and others working in public health mounted an advocacy campaign that got the decision overturned. So disabled people are considered a health disparity population by NIMHD. Yet I want to argue here that this case study is still instructive because it helps us articulate the ways that ableism is reproduced in this specific instance and in public health more generally. It allows us to imagine how things could be different, for better or for worse, the next time around, and perhaps we're living that next time around, in a domain that has and will continue to be consequential for all our lives, however it is structured. So with that, I just want to say I look forward to being in conversation with the other presenters, and thank you so much to all of the attendees and the symposium organizers.